I am Ira Kirschenbaum. I am the editor of the Journal of Orthopedic Experience and Innovation. Tonight, we have an exciting group of panelists, as well as a very current and important topic, meniscal repair, specifically meniscal root repairs and novel innovations. I'm going to have the faculty introduce themselves. We'll start with Nirave Amin. Introduce yourself, Nirave.
Hey, Ira, thank you for having me. I'm an orthopedic surgeon, sports medicine, and adult knee reconstruction trained who practices in Orange County, California. 70% of my practice is sports medicine and 30% is adult knee reconstruction.
Excellent. And we have Nicholas Colyvas. Nick? Oh, you're on mute, Nick. You're on mute. You're on mute, man.
That would help. Thanks very
Yeah,
much for having me, and I really appreciate the opportunity. I'm Nick Colyvas from UCSF. I trained in sports medicine, private practice for over 20 years, and then joined the university just about 7 years ago. I am knee and shoulder arthroscopist, but my practice has focused the last decade or so on knee and very specifically on meniscus. And I'm director of our meniscus preservation program at UCSF.
excellent. So I'm just going to lead it off with a quick question, and then we're going to get into the specific innovations. I've been in orthopedics a while, and about 10 years ago, we had meniscus repairs, and then all of a sudden, this concept of the meniscal root came up. So either that's a virus that caused this concept of a root to appear in people, or someone discovered some new anatomy. So, Nick, why don't you explain to me this this important uh, new world of root repairs?
Yeah, so great introduction to a sudden epidemic, right?
Right.
And I think that what people have said before is that we may not have seen it, but it's seen us is really appropriate here. I'm pretty sure 20 years ago I was debriding root tears and not knowing what I was quite looking at the time. Um, uh, 2013 or so, when I was involved with the development of the Soterix device, we started looking for things that may be applicable. And that's about the time when, people much smarter than me started realizing that these root tears had some real significance, in as much as once they happened, you lost your hoop stresses, and now you have an accelerated path to degenerative arthritis of that usually medial compartment. So that's when I sort of first started recognizing those, and I think now the data has come down. We're well over a decade into this. The sort of landmark papers were coming around 2015, 2016, showing us that this was something we should do. I think we're actually in a sort of second phase here with what we are doing. I think we are better at realizing what the correct indications are. We're better at recognizing this early. There was a bigger problem where people were not didn't have a high enough index of suspicion that this could possibly happen, and we're getting the MRI 6 months or 9 months after the injury, which is kind of late. So I think we're in a second phase, like I say, where we're really fine-tuning things like indications, we're fine-tuning techniques, we're fine-tuning fixation, all of those sort of things.
Excellent. Narav, some comments on this?
Yeah. I mean, the interesting part is I would tell you, and I would echo Nick's statements. If you think about it, even from a perspective of where we are a decade ago, as Ira, you said, hey, what do we do with these? Where were they? To where we are now. I did my fellowship in 2013, 14, and I did zero meniscal root repairs during my fellowship year.
Wow.
Right. So if you think about that percentage, and I will tell you the fellows that work with me now, they see anywhere from 30 to 50 in a year, right? So clearly there is a disease process in a state that historically we debrided or ignored until a total knee was indicated in that setting in space, that we've really changed the paradigm. And to be fair, if we can redistribute those hoop forces and we can stabilize the posterior horn of the medial meniscus and or lateral meniscus, right, we can really change the trajectory of this patient's life. I think when people talk about it, Ira, you know it the best. When people just go to a knee replacement at time zero and don't
Mhm.
understand the ramifications of a total knee, I think they're doing a disservice to the patient and a disservice to the community. There's options available we have. I joke a little bit. I mean, I really enjoy Nick's posts, right? I call them Meniscus Mondays, as Nick calls them. They're really engaging, right? Because they show you a value add of images and stories of patient scenarios where most surgeons will actually do a meniscectomy in that setting. And Nick will go back. It'll be a red white tear. You'll see Nick debride it to the back wall. You'll see him do variations of meniscal repair fixation that handles a problem and a pathology that historically we just debrided with a shaver, right? People would take a
Right.
bite or just clip away, take a 3-5 shaver, and then if they couldn't get it with a 3-5 shaver, they just switched to the 4-5 shaver. So we just got to be more aggressive. And I think as we've evolved, we've actually delayed these surgical paradigms where patients are getting better outcomes down the road. So I think there's a real paradigm shift in orthopedics that has a clinical value add for the patient in that setting and space.
Excellent. Excellent. So we have, first of all, a little bit of a slideshow and a presentation, right, Nirav?
Yeah, we do.
Is
Erica, do you mind letting Dr. Liu share the screen?
Yeah, he has sharing privilege. He should have sharing privileges.
Awesome. And while the slides come up, it's really interesting. If you think about the work, Robert Leprod's done a lot of work on the biomechanics. And if you look at the biomechanics of the root, it's really interesting to observe. Nick, I'll ask you a question off the bat. What is your post-operative protocol for a meniscal root? So let's say medial or lateral, or does it change one way or the other when you think about the meniscal root? Like, or do you go, do you let them weight bear? Do you not let them weight bear? I know there's a little bit of debate on even the weight bearing status at time zero. What are your thoughts on that, Nick?
So I'll tell you that the data, as far as high level, level 1 and 2 studies is not out there, right? The AOSSM did a consensus study, and there was, a consensus on rehab protocols after meniscus repair. And there was good correlation between the experts, but the level of actual evidence wasn't that high. So I think we have some consensus, and generally, if you look at that guideline, the consensus is that for root and radial tears, which really are sort of variations of each other, right? They're essentially tears where you lose all your hoop stresses. Repairs need about a 6-week non-weight bearing and a flexion limitation of up to 90 degrees for the first 6 weeks. Now, I'm more aggressive. I think over time we've gotten better at our repair techniques. We build a more robust repair, and so, but I'm not down to 2 weeks or no weeks. I still non-weight bear for 4 weeks, which
Hmm.
is still cruel and unusual punishment for the patients. But I think we are at a point where we still don't have a robust enough construct that we can weight bear them early. So I think, and I also think that maybe more importantly than the weight bearing flexion, beyond 90 degrees really puts a lot of stress on the meniscus. And so I think that will be something that stays. But over
Hmm.
time, I believe we'll be able to get patients off crutches sooner.
Yeah, and Nick, it's
Excellent.
really interesting, right? Let's get into that a little bit, right? In the current setting or space for meniscus repairs, right? The thoughts are for meniscal root, right? Radial tear, mid-body radial tear, lateral meniscus, or a posterior horn, medial or lateral tear. Traditionally, we fix them over two tunnels and over the bone, tying it over with two separate tunnels, either a button fixation and or an anchor fixation. I
Right.
think we all will agree that all three of those fixation methods have some level of cyclical displacement that takes place over time. You subtly said something that kind of crept in my mind a little bit. Are your thoughts based on the weight bearing because of the location of the tear related to the fact you're worried that you're not the hoop stresses that are undergoing on weight bearing, it may displace some of the fixation at time zero because of the load that hoop stress is going? Like, Is that a concern that you have at time
Yeah,
zero?
absolutely. That's I think my primary concern. For example, if we have a bucket handle tear or a vertical tear where the hoop stresses actually compress the tear, right? The sort of axial weight bearing will push that meniscus together. I'm only non-weight bearing those patients for 2 weeks. Horizontal cleavage tear is only 2 weeks. But a radial tear where you're threatening essentially extrusion of the meniscus, I think those require, more protection, unfortunately. They need, like I said, they need a very strong construct, the best we can make. But they still need to be protected, unfortunately.
Yeah, I agree, Nick, and I think that's the concern we all have, right? Is at time zero, your concern is the fixation method, no matter what construct you decide to have, you're worried that if the hoop stresses are coming on the meniscus, that you're going to get some level of loading that's taking place. If you non-weight bear them, they're not seeing those hoop forces as robustly, and that may give you a little bit of break or parameter in that setting in space.
Absolutely. I think that's key. I mean, we can spend a lot of time talking about what specific construct the suture material is in, sorry, the suture itself is in the meniscus. And what configuration, double loops, Mason Allen, ripstops, all of that stuff. I think that's a place where we need to be secure, but we also need to be secure on the tibial fixation. And now I'm assuming here, we can just sideline really quickly here that most people today, 2025, are using a transtibial technique to fix a root. I think there was discussions and people were trying anchor fixation right there, but there is, I think now transtibial fixation. Of course, there's aperture fixation as well that's available, but I think most people are still doing, I mean, the standard root repair is a transtibial repair at this stage, and with good results.
Yeah, so Nick, I'm going to add one more level to you, right? Now there's this centralization, right? So you
Yeah.
do the root repair, and now there's this debate of the centralization. Your thoughts on that? Like, do you believe the
Yeah.
forces are robust enough that you need to do a separate, mini approach through the MCL, get an anchor down, centralize the meniscus, and do the root on top of that? What are your thoughts on that?
Yeah, so I think centralization is still a little bit of a black box. We're pretty, like I said, I think we're in phase one with centralization, where we were 10 years ago with roots in general. Um, Centralization, I think, has some promise, right? We know extrusion is not good. We don't like extrusion, whether it's in a root, whether it's in a transplant. We don't like extrusion. So we also know that a good number of the regular roots we do don't. They may heal, quote unquote, but they remain extruded when you look at an MRI 3 months or 6 months later. So I think centralization holds some promise, but we don't know for whom we should be doing it for. What is the best technique? You just described an outside in technique. You could do a double tunnel technique as well. So there's two different sort of schools of thought there. Um, and I think that, the very best sort of way of doing centralization and whether or not it actually longer term provides the benefit we think it does, I think is open. I just saw a patient today who had a root tear, 5, 6 months ago, and there's a gap. And I know that when I get in there, when I try and pull that meniscus back to where it's supposed to go, it's going to have difficulty. So I've booked him for a centralized repair. He's going to get a double tunnel. Um, I think that is something we still need to work on, and we need to get sort of more information. It's still in early stages, but I think it does hold some promise, and I think that it's important that we figure out the best patient to do that in and the best way to do it.
And
Nirave.
Nick, here's exactly what you just said, right? This is exactly what you said is critical, right? At the 90-degree flexion mark, Harner did this really nice biomechanical study. You can see the load pressures, right, that are taking place. So historically, in 2008, right, when we did subtotal meniscectomies, the contact pressures you could see on the image on the bottom right sees a tremendous load, right? But if we can repair the meniscus and repair the root, you could see how the contact pressure significantly decreases at time zero. So I think there's a real value add in that setting in space. And I think this is one of the pioneer works that kind of led to the concerns of, hey, should we fix the meniscal roots in this setting? Because if we don't, then they essentially are getting equivalent peak forces as a subtotal meniscectomy. Any thoughts on this paper, Nick?
Oh, I mean, I think this is sort of one of the classics. This is the sort of save the meniscus flag out there. We know that contact pressure goes up if you take your meniscus out. I think there's a role for meniscectomy, but it's a lot less than it used to be, that's for sure.
Yeah, I agree, Nick. I think this is kind of one of the landmark studies, right, that the residents should read on all levels. So if you look at this, right, if it's a non-anatomic repair, and this is very critical that Nick you alluded to, right? When you're performing a meniscal root repair, I think the most important thing to do is actually make it anatomic. So, Nick, I've watched a ton of your videos on LinkedIn. They're very well done, right? You take a very critical aspect of decorticating the footprint. You're very careful putting the guide to the back, finding the guide wire, having it recreate or restore the footprint. I think we'd all agree when you have a non-anatomic repair, you could literally see the difference in the pressure contact forces when you don't do that. So Nick, can you give me a couple of tricks or pearls that you would do? Let's say I have a posterior horn, medial meniscus root tear. Where do you come from portal wise? I'll share my tricks after go over yours, and then I'll share my kind of tricks overall.
Yeah, so I have a standard technique, but to be clear, I do what works best for the particular knee I'm working with. So usually I'm coming in, anteromedial, and I'm looking at the root, and I'm getting the guide in, from the anteromedial portal. I do tend to drill from the medial tibia upwards, but I find sometimes that doesn't give you a good trajectory. Your guide doesn't work well there. I will have no hesitation to go onto the lateral side of the tibia to do my drilling. And the angle there is different, and it might actually be a little of an advantage. It's not quite a acute angle when you come from there. I don't think it makes a big difference. I think the key part is where your aperture is, which you alluded to, which is you've got to come out at the root. That's where you want the root to anatomically go back to. So I think it's dealer's choice when it comes to whether you go medial or lateral. I've heard arguments either way, but I think it's where you come out which is the critical part to it.
Yeah, Nick, and I agree with you. So listen, I do cheat. I actually, if I'm doing a medial route, I actually put my guide in the lateral portal. I view anterior medial, and I actually make my pass from the lateral portal as well. I find it's easier. I know some surgeons will do a reverse notchplasty to open up that view, right, to get through, or they'll pie crust the MCL. You've done really nice work. You've actually published in this as well, right? Pie crusting the MCL, better healing rates on the meniscus, right? Opening up that window, seeing, making your pass and fixation on that setting. So I pass my guide laterally, I bring down through my lateral port and go from there. Nick, there is a question. Is there an upper limit of age for these repairs in your opinion?
So there's a nice study out of I think it's the AOSSM journal showing that age is not a particular factor. However, I will say that my range, and I know this because it happened about a month ago. In 1 week, I did my youngest patient and my oldest patient in the same week. My youngest patient was 29, which is pretty young for a root tear. My oldest patient is 75, which is pretty old for a root tear. Once you get to 75, I think you have to have every other factor has to be perfect. You have to have excellent cartilage. You have to be active. You can't have a high body mass. You have to have good alignment, very, very important. All those other factors have to be perfect. You have to have a perfect history. And then I'll consider doing a root repair. But in general, it's pretty rare to have all of those factors in an under 70-year-old. So most of my root repair patients are 55 to 65. I don't have a specific, I won't call it an absolute limit, but I would say I've got a handful of patients who are, 70 or more, and I do a lot of roots. Huh?
Yeah, and Nick, in reality, right, most of those patients are females. maybe a little heavier set, right, in reality. But key point is you mentioned, right, articular cartilage. Like if you have grade 3, grade 4 on the tibial plateau and the femoral condyle, I'm not sure you're adding a much value add
I
proposition.
don't
It's
I don't think at any age you should be doing a root repair if you've got those factors. Again, it's
yeah,
not age is just one of the factors you tie into it. And the reality is at an older age, many of those factors are in play. The older patients have more cartilage defects, older patients, tend to be in more varus, etc. So I think you just have to evaluate it on a case by case basis. But I just think age is an important number, but it's not the only number.
yeah, great comments. Like, and as you said, right, transtibial. I think every other approach, I think universally we can all agree coming out of this talk that a transtibial repair is kind of the standard of care for meniscal root.
It's just hard to get back there otherwise. You know,
Yeah.
until we get an anchor that we can turn around at 100 and 80 degrees and plant it in there, it's just hard to get back there accurately to be able to use that.
Yeah, and so here's where some of what Nick you talked about a little bit earlier, right? Is the pullout of the meniscal root, right? Simulating the rehabilitation, right? The biomechanical study. This was done, right? Looking at like the cyclical load and the displacement. And this is part of the reason, right? Most of us will not weight bear them, as Nick, you and I are talking about, right? There's a concern of whether you do a single tunnel or double tunnel, right? About the cyclical displacement that's going through when they're going from 0 to 90 during their rehab phase, right? Where our fixation can hold us in a static plane overall.
Absolutely. Look, I think, that's the concern here is that um, what we do at point zero or at time zero is something we'd like to maintain through the healing phase and onto sort of a longer term situation. So the factors that affect that, the loading and the cycling really need to be sort of looked at carefully so that we can optimize it.
Yeah, totally agree. Next slide. So here, Nick, why don't I give you a case? Why don't you look through it, think about it? So 54-year-old female, 6 months of knee pain. We tried some PT. Really not any past medical history that's really significant outside of diabetes. Medial joint line pain, standard exam on the meniscus. Medial joint line pain, positive McMurray's. And any thoughts that you would want, Nick? I'm going to show you the MRI next. Next slide.
Yeah, so just going back to what you told me here. So I mentioned this earlier. High index of suspicion. So why didn't this patient, they're right in the target zone, 55 years old, knee injury, probably had swelling pain, maybe have gotten a little bit better. Probably, whoever saw this patient should have suspected that they had a potential for a root tear. They're in the target. I'd also, before looking at the MRI, want to see their alignment films and their X-rays. But I'm happy. Let's go take a look at
And
the.
Nick, I'm going to cheat and just take my word for it. The alignment is normal.
Yeah, no, it's fine. I just want to bring out all the points.
Yeah,
When I see
sure.
these patients, I want all of these factors in front of me so that I can make a good decision.
And Nick, we have an interesting question, right, from one of the members who's listening in. Interesting, right? So, what about a radial tear adjacent to the
Yeah,
root, which is common, right?
yeah.
Do we need to be a little bit non-anatomic to avoid tensioning on the repair? Do we release the meniscus off the capsule as an option? I will tell you, I do release it off the capsule. I make sure that it has a little bit of extrusion to come back in this setting. I think I don't over tension it, or I don't pull as hard as I can. I think for me, a tear that is slightly adjacent to the root, these are the ones I like doing a centralization on to decouple the force coming down. And when I pull it down, I think of it as a pants over vest technique. So often, if it's adjacent, I'll repair the root to where it lies anatomic, just adjacent to the root, and then I'll actually put either an all inside, all suture technique going to one above from a horizontal repair above and below. So it kind of creates a pants over vest technique with a belts and suspender. So that's kind of my go-to. Nick, what are your takes on these?
Yeah, so a couple of things. So if you look on my YouTube channel, there's something called a combined repair, which I think is exactly what you talked about, where there's a drill hole that is doing a root repair, and then it's taking that little flap. So this is the whole story is all about that little flap. how big is that little flap? What can you get into that little flap? If that little flap, that medial root flap, is big enough for you to do a hashtag on, you could do a hashtag and repair it as a radial tear. Usually it is not. Usually that piece is too small to handle those sutures. So I would do what you did, which is a root repair. It's not in an anatomic position, but you fold over the flap and hold that in place with an all-inside device or a side-to-side circumferential device. And that will theoretically provide your meniscus continuity. I think that also if you have a small fragment and you do a side-to-side repair or a hashtag repair, you're not going to do a transtibial tunnel. That's where centralization would be important, and you're going to get a tibial tunnel anyway. But it's tough in terms of releasing the capsule. I do that, but I do it in a limited fashion. At the end of the day, that's where the blood supply is coming from, and so I don't think you can just um, cavalierly just cut that capsule open and bring that thing back where you want. You'll get it back where you want, but then it won't have any viability. So I do that to some degree. It's a little bit of a trick to how much to get it there to move. But I think a combination of those things usually gets you back to where you need to go.
And Nick, you make a critical point, right? If you release the capsule right where your repair site is, your risk of leading to avascular meniscal repair is higher, right? So for me, I'll often release it either medial or lateral, and
Further
I'll do a
over.
small
Yeah.
release with the rasp very
Yeah.
carefully. But if
Yeah.
you do it exactly where the meniscus is torn, you're really doing yourself a challenging repair site because the vascularity is compromised, and now you're really compromising it moving forward. So I think Nick, you will agree with me. You see you could see the radial from the coronal views. You could see the meniscal root tear, right? You could
Yeah.
see the separarization coming through there. So next slide. So here's a video intraoperatively diagnostic repair, right? Some changes in the articular cartilage. You can see there's a probe going in. There you can see the clear root tear. Nick, would you agree root tear clearly defined?
Yeah, I think I mean, just from what I saw there, that's clear enough to me. I could tell you that's a root tear. Now I'm looking very carefully. What does that little piece look like?
Yeah,
Is
agree.
it how much viability, how much strength does it have? I'll get a grasp on that. I'll pull on it and I'll push on it with the probe. I want to see if I can get sutures in there, and that's sort of a critical thing for me. And
Yeah,
also remember when you put your shaver in to debride that, it's suddenly a bigger tear than you thought it was.
yeah, totally agree. So next
Yeah.
slide. So just kind of what you're talking about, right? So there's a pass coming from the medial side coming through. You can see I'm kind of looking to just see where the extrusion is. And
Hmm.
there's one luggage tag pass coming through overall. And you could see the extrusion even without the meniscus repair coming through. And then you can see that second pass coming through as well, making sure you have a little bit of decortication coming through. You can see the guide wire coming through from an anatomic portion there. You can see the footprint is really important for me. This is really important to use a footprint. You could use a Houston suture passer. I think depending on the AC, you could see how if you use a Houston suture passer, it's a little bit cheaper, but you can see the compressive forces here coming at time zero. So, Nick alluded to it a little bit earlier. There's two options for me that are tricks, right? If that was a tight area, you can pie crust the MCL. And Nick, I'd love to hear your thoughts. Where do you pie crust the MCL to open it up?
This is the question that comes up at every single meeting. Um, it's a bit confusing because people have described many different ways of doing it. And the original description was to do it at the femoral footprint,
Yeah.
where, theoretically, when you have an MCL injury, that's where you normally tear them, and so they heal well when you do that. But the reality is, if you try that in the real world, in a cadaver even, or on a patient, it's quite hard to get that to open up very well. And it's a difficult place to do it. So there's been a number of different methods described. What I've sort of developed over time is going to the posterior aspect of the MCL. So you're sort of at the deep MCL and the POL. And there you put the knee under valgus pressure, just above the joint line. You make your pie crusting there. If you get it just right, that's like a sort of a magic spot. You just need to put in less than half a dozen pokes with the spinal needle, and it opens up in a very controlled fashion.
And Nick, really
Um,
quick, not to
yeah,
interrupt you, what size spinal needle do you use?
18. I
Okay,
use an 18.
thank you.
Um, and actually, if you look at some of the work around what the basically the MCL complex is, superficial, deep, and POL, by going to that area, you're actually not introducing as much rotatory instability by releasing the POL. The POL does not actually contribute to rotatory stability as much as the deep and the superficial. So I like that spot. I like the controllability of it. Some people describe having to really just put massive valgus on the knee to get it to open with pie crusting. With the way I've just described, I find that it's very controllable, and the forces you need are not great. You just get it in the right position, and that will open up the knee. Harder to find those with bigger knees, but the landmarks. But you can also transilluminate with your scope, put it right at sort of the back of the MCL from the inside, and that'll help you see where you're going.
Hey, Nick, that was great. Thank you. I think that is critical what you just went over, right? The MCL pie crusting, which is absolutely critical if you're going to do meniscal work in tight corridors or tight spaces. You could see the meniscus in that video come down and under compression. Next slide. So how do you get it, right? So I think this is where it gets a little bit interesting. So Nick, I'll walk through this one a little bit. Anyone who has not seen this, this is a new implant, which is called the Washer Cap Mini, which essentially is an implant. And just so everybody knows, it's got a biplanar fixation. So I drill the 4-5 hole up top. It's going in an expedited manner, but essentially you drill that little hole with the sleeve. And what I'm doing is I wrap the suture around the little screw going in. You see the screw actually has a little step off, right? If you look really closely, once I wrap the suture around, very easy to do. Now what I'm doing is now I'm twisting the screw and I'm bringing it down, and you just saw the screw break, and you may say, oh my God, that's really unfortunate. The screw broke, but actually that screw is a self-limiting torque screwdriver. So what it does is it actually tells you the torque and the tension on the screw is in an ideal position. So you have adequate fixation in that setting. And right there, you could see that screwdriver broken. So that's actually meant to be a safety valve on that setting. And Joe, if you can back up the video just a touch, go back a little bit further. What I wanted to show is the tails of the suture come down, and go back to the beginning of the video, Joe, a little bit further back. So now this blue implant is basically an all disposable implant that comes in. You go through your 4-5 hole. Now you have a second hole now. You pause it right there. And that's actually the drill hole where your screw is going to go in. So you're getting biplanar fixation. So remember, every fixation we've ever known and the knee arthroscopic space has always been in the plane of the screw or the plane of the tunnel. The idea behind these implants is you're getting this biplanar fixation so you don't get the cyclical displacement. My thoughts are if you're not getting cyclical displacement, like you looked at Laprod's work, right, where you're worried about you're losing some of the footprint, are you going to be able to rehab these patients a little bit quicker, Nick? Let me ask you the question. If this implant biomechanically can show that you're not getting cyclical displacement and is able to hold the contact pressures, Nick, would you change your rehab protocol?
Yeah, look, I talked about, the rehab protocol. I've gone from 6 weeks to 4 weeks. I'd love to go to 2 weeks. This is the type of innovation, or this is the type of construct that I think would allow me the confidence to do that. I need to see more data. I'd need to see it in practice more often. But this is the type of thing where I think you can start pushing the envelope a little bit. Once I can go, I can take a step back or two here before we talk specifically about, this particular implant. But, the traditional method for tibial fixation has been either a button or an anchor of some sort, right? Your typical bone anchors. Both have significant problems. And I think once we recognize that and we're able to use those effectively, and I'll tell you right now, my sort of fixation method right now is both a button and a backup anchor. So, because I think tibial fixation is extremely important. And so that is, sort of maybe a bit pants over vest and maybe a bit over engineered for the tibia if you're going to use both implants. It would be nice to use one implant that did, uh, you know, did the job properly instead of relying on one and having a backup as the second. But I think tibial fixation is really key, and it's, things like clearing the bone surface so you can really see it well and you don't get periosteum or soft tissue in the way is exceptionally important. I think that checking your tension after you do it and making sure it's okay. And here we bring up the point of retentionability, right? So maybe you go back in afterwards and hell, I really hate the look of the fact that that has loosened up a little bit because I moved the knee around and I didn't quite have it right. So the ability to retension, I think, is a massively important point here because you can't leave the operating room with those sutures floppy. It's just not you've sort of done all the surgery and now you've left it sort of floating. It doesn't work very well. So I think my thoughts are that it's really, really, really important to get excellent tibial fixation. That's my baseline thought there.
Yeah, and Nick, great point, right? That I remiss to say is the key aspect to this setting, right, is if you don't like the tension, you can actually put the screwdriver back in, look in the knee, retension it, and then lock it down, and then not get the displacement that you would normally get. So I think there's a real value at it. I think what you said on the tibia, right? It's always been a source of like a little bit of angst, right? Even in ACL fixation, people all often use screw fixation with backup anchors or all button fixation with the backup anchor to hold it in place because there's a concern that there's some level of cyclical displacement that's going on between the graft interface into the actual tunnel interface and so forth. So great points, Nick. Next slide. So Nick, I'm gonna shift gears because we're in the last 10 minutes. So I'm gonna give you kind of the real world life that me and my partner actually we take call it a level one trauma center. So I think most sports guys look at this and say, "Oh my God, what the heck are you guys doing?" But I'll give you a real story. A 32-year-old comes in, head-on collision, hit by a drunk driver. So this is what he shows up with: right both bone forearm, right medial mal, left distal radius, left medial mal, left patella fracture, and left tibial plateau fracture. So my partner actually was on call. He's a sports guy actually and fixes everything on day one. But we have a little bit of a problem because on day one, there's a little bit of a problem of a tibial plateau. And let me show you next slide. So this
Hopefully you didn't do the colon too.
I did not. But now look at this tibial plateau. Right. So now we have a problem. Dr. Liu, are you on by chance? You may be on mute.
So I got distracted by that
Yes.
patella, but
So here's
go
the
through it one more time because
so,
yeah,
so
I'll
Nick,
focus on the tibial plateau.
So I'll give you a fascinating thing about the patella. You're going to see this fixation. So we actually used, even for
Yeah.
the patella, we used actually a disposable patella, sorry, a single-use patella plate that actually has a suture built into it. And you're going to see the fascinating part is on post-op day two, Joe went and Dr. Lou went in and fixed it on day one. And you'll see we're fixing the PCL within the 90 degrees the entire time. And the entire fixation holds the entire case, which I thought was really interesting.
Yeah,
But that's a whole separate talk. But for the plateau, Dr. Liu and I thought about it at length. Dr. Liu, jump on really quick. What are your thoughts here? I know when you first saw it, posture approach, what are your thoughts here?
Yeah, I think the issue is, you don't know what the strength of your fixation of the patella first is. And so initially the thought was, well, maybe someone goes prone and does this open because they can keep the knee in extension. But then you're in the back, and how many posterior approaches have I done in my career? Exactly zero, unless I'm with a tumor guy, right? So, I think that is, I think that is the reality of this is you either have to go potentially arthroscopically from the front and be at 90 degrees, or if you want to keep it straight and you're really worried about your patella fixation, go prone in extension, right?
Nick, what are your thoughts here? Where are you going?
Yeah, look, I mean, in all honesty, I'd probably run it by trauma guys, and they may say, "Oh yeah, we'll just do a posterior approach." But if it's my patient's my case, and I'm looking at this, I'm a sports guy, I'm not a trauma guy, so I'm looking at this as an arthroscopic case where I'm going to set up posterior, medial, and lateral portals, and I'm going to put that thing down. And now that piece looks to me like it could, accept essentially a transtibial pull to get it back into position. I think maybe the traditional method would be with screws and put it down, but I look at that more like a PCL avulsion. It looks to me like it would be amenable to that sort of approach. Which is always a satisfying surgery when it comes right, because you pull that thing down, and you can get it to go. But it's a bigger piece than we normally see for a PCL avulsion. But I think you could probably get round it and pull it back down that way. That would be sort of my approach. I would, yeah, always run it by a trauma surgeon, just because of the nature of it. But that's what I would give a try here if the patient was up for it.
Yeah, and Nick, good points, right? I mean, we ran it by our trauma team as well, right? We have three fellowship trained traumatologists, and they basically said, why don't you try something arthroscopic? Because that's a tough approach posterior going in the back. So openly, Dr. Liu and I kind of thought about this for a while. I think our concern was, well, your concern was, right? Normally, if it's a PCL avulsion, small fragment, bring it down, tie it to the PCL, tunnel it down arthroscopically. Now, this is a larger fragment. So there's a larger concern here that comes through. And what fixation, openly, there's going to be so many forces on that PCL fragment bringing it up. What fixation can we have that can hold it at time zero in that setting in space? So that became two. Next slide. So, right. So we talked about this, right? Options, tibial plateau, right? Posterior approach with a trauma guy, arthroscopic fixation. Next slide. So let me kind of walk through so Joe, why don't you walk us through this? This is the posterior portal. Joe, why don't you walk us through what's kind of happening?
Yeah, so introducing the posterior portal, that's the cannula through the back. I think, this is a camera coming from the medial anterolateral portal, and you basically, once you establish that posterior portal, you can basically come directly down on the tibia. And as long as you're pointing that radio frequency one or any of your instruments anteriorly, you're kind of staving away from the vessels. It's pretty safe, I would say, especially in 90 degrees of flexion. So then we pass the PCL guide from the front. This is from the anterior. We're looking from the front through that, and then we're looking from the back now. So we're looking from that posterior medial portal, and we're trying to use this guide basically to lever that post-tibial plateau back into place. So you can, oh, sorry, that was a little too fast. But you can see how it's now reduced that fragment down as you lift your guide up. And we basically, just like a PCL reconstruction or repair, we basically drilled a tunnel and passed our suture. And what we're doing, because we're worried about the size of that fragment, instead of just using a PCL repair technique by itself, we've actually passed what you'll see is a large, kind of like manhole button, like you'd see in an ACL, to compress the fragment. So you'll see some kind of final fluoroscopic images in a second as we repair it. Basically, you see that button, and so I'll show you just the kind of the entire sequence of things, but that was done arthroscopically. But on the upper left corner, you can see that fracture with it displaced. And then as we put the guide in, we can reduce it with the actual guide in place, drill the pin up. And then we did pass one suture through the PCL first to kind of pull it down, like Dr. Colyvas was saying about just doing a PCL repair. But because that fragment was so large, we used the additional button in order to compress and just expand the compressive forces of the button. And then we actually used two tunnels for this through two washer caps to basically lock down the fixation. So, the worry is if you do it through some sort of button in the front or suture ankle or even adjustable loop, like say you had like an adjustable loop down, you actually might have displacement as the knee cycles. But with the washer cap fixation, the displacement is like less than 0.4 millimeters. So you're going to maintain essentially that compression you've achieved in the operating room to basically allow the fracture to heal. And then, like Dr. Amin was saying, the patella fixation fortunately held up through the 90 degrees of fixation.
Looks lovely.
Yeah, and Nick, you made a critical point, right? The critical point is, I think if you're going to do it from a sports perspective, something like this, right? You whatever fixation you have on the tibia has to have some level of constant static fixation because any kind of creep displacement here, right? No matter what you use, you're going to widen that fracture gap and you're going to know allow the synovial fluid to trap in, right? Where you can have a potential risk of non-union. So I think it's very critical when you're choosing implants for any level of surgical fixation that you're choosing them based on the ideal patient population. So I think when we think about the root, what Nick and I were talking about earlier, or you're thinking about a case even such as that, you should choose your implants that match the outcome which you're hoping to achieve. So as Nick said, when in his current fixation for meniscal roots, he's concerned about the fixation. So he'll use a button and then back that up with an anchor. So if there's an ability to use some level of an implant or a device where you're not going to have that cyclical displacement, that gives you a value add perspective where you're not going to have the deformation and you're not going to lose the contact pressures at time zero, where you can actually change the outcome with the recovery style, where the rehab can actually accelerate to a certain level. So I think all those are really critical points when you're thinking about meniscal root. When you're thinking about anything arthroscopically, we're going to have some kind of fixation where you want to have some level of whatever you're trying to fix in a static level. Nick, your thoughts?
Yeah, look, I think that's all correct. I think that yeah, the less cyclic displacement, the better. That really does not help you in any way. So a construct and an implant that gives you that option is probably your better choice. In addition to the adjustability factor, because you can. I've actually used adjustable loops for these. It's complicated, and there is technology to do it, and that gives you a nice tight repair. But if you want to change that, you sort of bought it. You're not able to loosen it back up again and redo it in some way. So I think that the ability to have something that gives you a very solid repair, but then also allows you that time, that opportunity on the is maybe rare, but there's enough times when you might need it that it's nice to have that as an additional option.
Yeah, and I love that comment, Nick. I mean, you think about the rotator cuff, right? And we put our lateral anchor down. And if we don't like the fixation, it's not like we can go back,
Right.
right? You've bought whatever
You bought
fixation.
it,
Once the
yeah.
anchor is run, this has the ability, right, to have you have multiple levels of fixation and then openly do a second check, right? So you know when you're leaving the OR that you have a fixation that you're confident in, that at least you've optimized your surgical repair. And now it's up to the rehab and the biology that the patient has to get the maximum outcome.
That's the goal of every surgery.
And lastly, I'll kind of walk through this. For those who are a little bit newer to the technology of Abanza, I think it's really important to understand kind of the value add perspective of what the implant brings to the market. In the current setting or space, most of the implants are adjustable loop or they're based on some level of fixation from point A to point B. And when it's static at point A, so let's say the button is at a femoral tunnel. Once that's going over a load that's taking place through the cyclical aspect of flexion and extension, there is some level of loss or there's some level of fixation loss that happens over a period of time. The advantage to the Avanza implant is if you think about it, think about a road that's taking place, and now you've taken that road and you've drilled a separate line inside at an angle. So what you've done is now it's not fixed at one position in a road going in that line, it's locked. So then basically that load parameter, that displacement that can take place with other implants can't take place. The reality is the implant itself allows you the ability to not only have static fixation, but also the ability to double check your repairs and then retension it. There's options on the market that are available. It just launched a 3545 implant that's available for roots in cases like this, to be fair. So whether it's AC joint reconstruction where you want to drill through the clavicle, right? You want a small tunnel through the clavicle, or you're doing things like this where fracture fixation. The ability to kind of navigate this is new in the market space. And I'd urge you, if you're interested in it, where you have this belief of the biomechanical construct of sites, this has a real value add proposition in that space or setting, especially being in a static construct.
Nirav, can you talk about using it for an ACL as well?
Yeah, Nick, great question. So like on an ACL, right? In my current setting, in my patients, let's say there's a 56-year-old skier, healthy, wants to get back to active things. I do a soft tissue allograft in that setting, or if I'm doing a multi-lig, let's say I'm doing a 32-year-old, 34-year-old multi-lig, I will use allograft in that setting openly. In those settings, what happens, it's a tibial-based implant. What you do is, let's say your graft is 9 millimeters in size. So you could either go, actually, let me correct that. Let's go 9.5. So let's say your graft is 9.5. So what you'll do is you'll drill your traditional tunnels. And before you pass your suture down, you'll take a little 10 millimeter reamer and you'll just pop the outer cortex about 15 to 20 millimeters. And then you'll actually prep the implant hole with the 10 millimeter hole. And then you'll drill your bicortical planar fixation. And then you actually put the implant in. And then you take your C-clamp and you shuttle the tails of the allograft through. And then basically what happens is I would do cyclical loading at 20 times. And Dr. Liu, myself, and Dr. Flanagan actually just published a paper that's going to be in the Journal of Arthroscopy and Techniques. It will actually, you'll take out the creep deprivation from the femoral side on the socket the best you can. And then on the tibial side, you'll take your button in whatever degree you want to tension it at, and then you put your tibial screw down. And then you can, as you said, you can actually go back to then you can put the camera back in, and you could actually reduce any loss of fixation on the femoral side as long as your button hasn't bottomed out, and then retension on the femoral side. So you have a static construct at time zero. So big value add proposition in that safe space and setting.
That's
Right,
great.
Nirab?
Yeah,
Hi,
thank you.
Ira here.
Hey, Ira, thank you.
Yeah, let's get some final statements from both of you just to sort of wrap it up. Um, Joe, you could stop sharing the screen, I guess. Yeah, there you go. About the future of where this is going, what is preventing, just a bit summary statement, Nick. First you and then the Rav.
Yeah, thanks. I think this is sort of my summary is what I started with, or what I outlined in the beginning. I think that we are now in a place where we have a more mature approach to root tears and root repairs, and we are now trying to sort of fine tune that, improve it, and part of that is going to be, getting patients off the weight bearing or the non-weight bearing phase as much as we can. To do that, we need constructs that we trust, and we really need to be focused on improving the overall construct, and that's on both the tissue side and on the fixation side. And I think that this is the type of innovation that's helping us get there.
Yeah.
And
And Nick, look, the critical aspects are how do you get to an optimal outcome, right? And I think you mentioned, you hit it on the head, right? Um, Number one, the biomechanical forces, why your range of motion, right, is from 0 to 90. And then what are we doing in the current setting or space on the rehab side that's leading us to non-weight bearer for the period of time? And can we get to a better state or kind of navigate that space? And I think we went over it, right? I think meniscal root market, I think some it said, I think, Ira, if I'm not mistaken, I said I've seen some numbers as high as 100,000 being done in the US, and we're going down that trajectory. Nick, I
yeah,
can imagine, like, in the last 5 years, I'll just bounce one last question off you. What's your percentage of growth? I know I call you the meniscal whisperer, but like, what is your percentage, right, of meniscal root fixation you've grown, just roughly in percentage in the last five
Yeah,
years?
so I'll tell you that about 30% of the meniscus repairs I do, it's been this way at least for the last 5 years. It used to be 5%, then 10%, but now it's been stable. About 30% of the meniscus repairs I do are roots. Um, you
Yeah,
know, and that's I think fairly stable at this point in time. But the aging population demographic that our arthroplasty colleagues are seeing is also spilling over to us, right? We've got lots and lots of 50 to 60 to 65-year-olds who are coming into this sort of range and are going to develop root tears.
Yeah, and I think Nick, you hit the nail on the coffin, right? Is we evolve toward this subspecialization of sports medicine and reconstruction. The sports medicine doctor is going to try to navigate the patient longer and longer in their practice. And I think you're going to see this kind of continued growth in the meniscal root market. And look, I just hope people are open to the fact of be open to fixation methods and ideas and look at the literature, right? Try to follow the literature to get your outcomes to the best that we can. I think it's critical to understand why the outcomes are where they are, why they're failing, and how can we get better in the future. And that will kind of drive the science and the outcomes. And I'll leave with one, Ira. Nick said it earlier. There's no level 1 or level 2 study on fixation, right? Because the problem is historically the numbers aren't there to build that study, right? Individuals don't do that at high level of meniscal roots. So I think hopefully we can get there and go from there. I think Dr. Redler has one quick question. So I think Ira, if you're okay, we'll take it really quick before
Yeah,
we get off.
Red.
Yeah, he's such a nice guy. We have to get a question from him.
Ira, he doesn't want you to watch the Knicks game. He doesn't want you to
No,
see the
I'm
score.
okay with it. They're losing. It's okay.
The Knicks are going to win. It's a pleasure listening to two such outstanding experts in sports medicine. I got to tell you, if I came any later and I saw that multi-trauma case, I said, I thought this was a sports medicine case. We were off topic there for sure, and for a lot of eyeballs there. Two quick questions there as well. One, when are they going to come out with a non-metal version? Because a lot of us hate metal. John Rizzo, you can answer that. And two, what level of chondral damage would make you not do a root repair? That's good points for an awful lot of people on this call.
So as far as when a non-metal one is coming out, I'll leave that up to the Abanza people to answer, or maybe Nirav has some insight there. I have a kind of rule of thumb with the cartilage. Grade 1 and 2 is good. Grade 3 is the gray area. Grade 4 is a no-go. Now, so we always talk about the gray area, and the gray area is the interesting part or the challenging part. And that's where if I've got a grade 3, but all the other factors, stability, alignment, the history, the patient habitus, et cetera, all of those are good. I'll go, I'll go to the surgery in that case. But if some of those other factors are there and you've got a grade 3, then no, you're out. It's just a case by case, but taking all the factors into consideration.
So that's a great pearl to take home, everybody.
Yeah, and Mike, I think I don't know if you saw the root case that we showed a little bit earlier. I think it just depends, right, on the lesion of the cartilage. But I think grade 4 is a no-go, especially KL4, not a value add. I could share, John, if you want to jump on as well on the metal option. I think there's no secret. There's a little bit of a concern on the metal side. We are actively looking aggressively at options in that space. I think just like any startup, you're looking for optimization of utilization of implant first, right? So we're trying to learn. Every case we do, we learn a lot. And that's where we are on the early aspects as we evolve. We are looking at avenues or platforms to go down that space, right? If we can get down to the aspects of having a material that has minimal to no metal with this level of biomechanical work, I think that will take us to the aspects we're all looking to achieve.
Yeah.
John, anything to add?
Yeah, thank you very much, Dr. Amin. Thank you, Dr. Colyvas. Dr. Redler, you're absolutely right. This is a primarily peak implant, but and not just removing the metal. Our goal is to make this completely resorbable, and that's what we're working toward. And that may be a year or more, but we want a completely resorbable implant. That's our plan.
Great news.
Good question. So I am going to say, first of all, thank you to Nirav for moderating and making my job so hard tonight. Nicholas, thank you for coming on board. I want to thank Abanza for a great implant and a great solution to a serious problem. I identify as a joint replacement surgeon. I'm afraid you guys are going to pretty much put me out of business by repairing all these roots. So, I may start carrying some placards around. No, no, no roots, no roots. But the reality is, this is always the fastest hour in orthopedics. The Joey Open Mic Nights. You will be able to see this and tell your friends about it in a day or two when it's on our YouTube channel and our site. And I want to thank everybody for coming tonight.